with their time. Richard O'Sullivan is an absolute expert in prostate MRI, has been doing it for years, has read thousands and thousands of cases. And we together have been doing a prostate MRI MDM for several years. And it's just been a fantastic learning experience for everybody because we just get that instant feedback, both as urologists, but also for the radiologists involved as well, and the pathologist, in fact. So it's been a really worthwhile experience, and we thought, well, why not open it out to a wider audience, and obviously using real cases to do that as well. Morgan Pokorny is obviously a USANZ member that many of you will know, has trained in Brisbane and is now back in Auckland, and is also a urologist, but also an expert and author of many prostate MRI papers. So I'd really like to thank the rest of my panel for taking the time out to do this tonight. Before we get on to the bulk or the content of this webinar, please feel free to switch between this screen on your computer and the website where we're going to go through the cases, because whilst we're going to go through the cases, it would be even better if you can go through the cases yourself in your own time during the webinar. We're going to give you a couple of minutes here and there to do that. So if you go to www.mripro.io, and you'll see a little button called example cases. They're the ones we're going to go through together. So don't go through them just yet, because we will be doing it as part of the webinar later on. I can see our famous pathologist has joined the meeting. Andrew Ryan.
A few technical difficulties.
That's right, well done. Andrew Ryan works at Tissue Path here in Melbourne, and again, another expert on board who does, he's a uropathologist, and he and his colleagues at Tissue Path provide us with beautiful reports, including the volumetric studies that you're going to see in some of these example cases. So thank you very much, Andrew, for taking the time to prepare and for being part of this tonight. The other thing I want to say just before we get stuck into it is you should have on your screen a Q&A function, which means that you should be able to text any questions at any time on the screen into us, and we will read them from time to time, and hopefully we'll cover as many of them as possible throughout the webinar. So yeah, please get them in, because we don't want to just be rabbiting on at you. We'd love to get your interaction and feedback and questions and comments as well as we go through. So without any more further ado, I think we'll get stuck into the initial part of the talk, which is Richard really just giving us a brief intro. Many of you will no doubt be familiar with much of this, but I'm sure there'll always be bits and pieces to add to your knowledge. So Richard, if you're happy to take it away and take us through this slideshow, that'd be great.
Okay, let's get started then. We're going to talk about multiparametric prostate MRI. Okay, so what is PI-RADS 2? It really was just developed as a consensus statement of multiple areas of interest, multiple interest groups. It allows us to collect data, and it allows me to talk as a radiologist to urologists and to pathologists, so we're all on the same page of how we communicate, and also allows us to establish minimum technical parameters for us to perform the study. So the PI-RADS version goes from, scale goes from a risk of 1 up to 5, with 1 and 2 being highly unlikely to be clinically significant cancer. 2 is unlikely, 4 is likely to be clinically significant cancer, 5 is highly likely, and the one that's the hardest one of all is this one in the middle, the PI-RADS 3 lesion, which is the equivocal lesion, which is the I'm not sure lesion. It's important when we do this, we evaluate both the peripheral zone and the transition zone separately. So how do we do it? This is a picture of the scanner we use. It's a Siemens Skyra 3T MRI. You can see there's a tunnel here. The patient's lying on the table. There's a coil overlying the patient, and there's also a coil in the bed. So we get information both the front and the back of the patient. There's no indirect or coil. We use a total of three different types of sequences. We use small field of view T2 imaging to define the anatomy in the sagittal, axial and coronal plane. We use diffusion way imaging on various B values to give us a apparent diffusion coefficient, or the so-called ADC. The diffusion way imaging effectively gives us an assessment of tumour cellularity and cell density, and it's the single most important sequence we do. We actually acquire it in the axial and sagittal plane. And the third and probably least important sequence is the actual post-dynamic study, where we give the patient an intravenous injection of contrast, gadolinium, and we scan the patient every 4 seconds over 2 or 3 minutes. So the concept is that tumour cells have got more blood vessels, or the tumour's got more blood vessels, and they take up the contrast more quickly, so it rushes in. But those blood vessels are immature and leak, and the contrast then washes out. So we actually look at this area of the curve to see what the maximum enhancement is to give us further information.
Richard, before you go on to the next slide, sorry to interrupt. If you just go back to your DWI bit there, you know how you've got those different B values?
Yep.
You're saying that you acquire images for each of those B values?
You'll see if you look on our packs, there'll be one sequence which shows a B value of 50 and another B value of 400, then a B value of 800. And we actually subtract the 50 from the 800 to get the ADC, and we calculate to a B value of 1400. Yep. We actually also acquire a separate B value of 2000 as well. So this is one sequence, and if we do in the axial plane, that's one sequence. In the sagittal plane, that's another sequence. And if we acquire it a B value of 2000, that's another sequence as well.
So you mentioned that, you know, the DWI is that's really where the money is often with finding the actual significant cancers. Can you say that any of those B values are better than others in that regard?
That's controversial, but I think what we need is that we need a minimum of 1400. That's the most important part. So the one I call the high B value, that's the minimum we use. And that has become standard on the new PI-RADS 2.1, where it's compulsory to have it at 1400. So if you're having a B value of 1000, it's not good enough.
Yep. Okay.
And just to add to that, what do you see as the advantage of the B2000 then? Do you really think it adds much?
A little bit. Sometimes a lot of when I'm reporting, I'm trying to find a bit that stands out to me. So sometimes it stands out to me on one sequence or another sequence. So I'm constantly looking at something new to grab my eye. And if I see something that's obvious on the high B, then I'll go back to the other ones. Does it change my mind? Rarely.
Yeah.
Okay.
Thanks.
Okay. The arrow has gone somewhere. Okay, so these are the first sequence we do is the T2-weighted images. Each of these is a separate sequence: axial, sagittal, and coronal. If we look at this bottom right-hand corner, this is the T2-weighted image. It's white fluid in the bladder. This is the prostate here, the transition zone here, which has got these rounded areas of alternating high and increasing high and low signal intensity, with most importantly a well-defined black margin. And in the peripheral zone, it's much brighter, more homogeneous, with sometimes some stranding within it. On the sagittal image or the coronal image, we can see the seminal vesicles here on the hype on the coronal image, and the axial image, as I say, and here it is on the sagittals. This is bladder here, transition zone, peripheral zone, seminal vesicles, and rectum behind. Now, the problem with the T2A image, it's quite useful, and it's very useful in the transition zone, but other focal lesions in the peripheral zone, for example, hemorrhage, prostatitis, and scar, can all have an abnormality on the T2. So it's insufficient as our sole sequence, particularly in the peripheral zone. So the diffusion-weighted sequence, which is one we've talked about before. So this is the combination of, this is so-called ADC. So we've got those three different B values, which gives us an ADC. It looks like a poor man's T2-weighted image, where you'll still see white urine in the bladder. The transition zone is still black, and the peripheral zone is still bright. So we can actually measure the ADC in this area. And as a ballpark, when the ADC is greater than about 1000, it's almost definitely benign. I can do an area of interest around that. If it's greater than 900, it's likely to be a tumour. So the lower, on the ADC, the lower the signal, the blacker the signal, then the more abnormal it is. So the concept of cellular diffusion is really, it's the ability of water to move around the cells. So the greater the density of the cells, the less the water is allowed to move around, and that's so-called restricted diffusion. That gives us the signal. So the ADC is black. This is the high B value. You can see immediately that the anatomical information is not as great. So the background gets more obscured, but the tumour is supposed to get bright. This is normal, and a tumour would be bright on this sequence. So a combination of black and white would be abnormal, but this is normal. So the higher we go, the higher B value, for example, at 2000, the tumour is slightly more conspicuous, but the background is even more obscured. So it may or may not be useful. Okay, so the washout is probably the least useful one. It's only used in the peripheral zone, and we look to see whether if there's an abnormality on the T2 or the diffusion, there's a focal abnormality, whether we have focal contrast enhancement. This is the colour representation, transition zone here, and focal enhancement within the peripheral zone. It's either a positive or a negative. It's either yes or no. And the only time we really use it is to differentiate between a PI-RADS 3 and a PI-RADS 4 lesion. It's not really useful at all in the transition zone, as we have multiple areas of enhancement which doesn't allow us to differentiate between benign and malignant. So if we look about PI-RADS 1 and 2, I don't really use PI-RADS 1 very much, but this is what a PI-RADS 2 would look like. Axial T2 image, transition zone here, peripheral zone. You're allowed to have lines. It's allowed to be patchy, minimal lines, but it's not allowed to be a focal abnormality. So linear or wedge-shaped abnormalities are acceptable as a PI-RADS 2. This lesion, this slide below is the ADC. It's measured as 1600, so that's way above my area of confidence. So I'm very happy this is a PI-RADS 2. Does not got a low ADC. So this is a clinically significant cancer. It is important to know that MR doesn't really see Gleason 3+3. So this is 3+3 or less. So in the peripheral zone for a PI-RADS 3, you can see now we have a focal lesion. This is again the axial T2, transition zone here, peripheral zone here. There is a focal lesion. On the ADC, it's a little bit black. On the high B value with the black fluid in the bladder, it's a little bit bright. So it's got that number will come out at about 1,000. So that's the I'm not sure lesion. I call this a PI-RADS 3. If this focally enhanced, that would upgrade this to a PI-RADS 4. It is important that these patients should be biopsied with PI-RADS 3 because at least half of those will have a 3+4 or greater.
So Richard, I mean, when I look at this image, I'd be thinking more sort of PI-RADS 4, but you're saying it's a PI-RADS 3 because the ADC.
So this is not dark enough.
Yeah, exactly.
And this is not bright enough.
Yeah, exactly. Right.
So it'll be more, I'll show you a PI-RADS 4 in just a moment. So this is the example of the tiebreaker. So it's very hard to see the lesion at all in the peripheral zone, the T2 image. Maybe there's something there. This is a sagittal diffusion imaging. This is the ADC with white urine. You can see there's a lesion here that probably corresponds to this lesion. It does go slightly bright, so not really short. It doesn't go black enough or white enough, but it focally enhances with contrast here. So that upgrades this from a PI-RADS 3 to a PI-RADS 4. This is more obvious then. So this is in a PI-RADS 4. Again, axial T2 image, transition zone here, patchy change here, but a focal abnormality, which is very dark on ADC and very bright on high B value diffusion imaging. So this ADC value will be of the order of 700 or thereabouts. That's a PI-RADS 4. It must be measured less than 1.5 centimetres. So a minor increase of that is black and white is bad. The only difference between PI-RADS 4 and PI-RADS 5 really is the size. So this is an axial T2 image. Again, you can see this lesion here. It's greater than 1.5 centimetres. It does demonstrate some invasive behaviour. So it does go into the transition zone. There's some capsular irregularity here and an extracapsular mass. So that's clearly an invasive lesion, greater than 1.5 centimetres. But it's markedly decreased density on ADC, black on ADC, white on high B value diffusion imaging, and focally enhances with contrast. This is a typical PI-RADS 5 lesion, highly suspicious. So the ADC is by far the most important sequence in the transition zone, in the peripheral zone, I'm sorry. It's also extremely important in the peripheral zone, in the transition zone, sorry. So in the transition zone, this is a sagittal T2 image, bladder here, rectum here, transition zone, peripheral zone. And you can see in the transition zone, there's lots of brown, black areas and lots of white areas, but there's a black line surrounding all of these areas if you look closely. That's very important to look at the margins of the lesion, of the abnormalities within the transition zone. When it's like this is a PI-RADS2 lesion, you can see this is, it's inhomogeneous enhancement throughout. This is a term's been used, this is organised chaos. There's just bits and pieces all over the place, but they must all have this well-defined margin.
Richard, you mentioned that you rarely report PI-RADS1, and that's for a very good reason. You basically have to have a almost normal prostate to do so, except I note that in the PI-RADS version 2.1, there was a bit of an alteration on that where, sort of perfectly circumscribed BPH nodules apparently could now be called PI-RADS1, but even they seem to be pretty rare.
Yeah, no, I think the concept for you've got to look at, I look at this, we've got 3 planes of the T2s, and if I can see a well-defined black line around in 2 of those 3 planes, that's a PI-RADS2, but we could argue about a PI-RADS1, but neither of those need to be biopsied in their own right. I think that's the important part.
Yeah, agree.
So we can have the tiebreaker in the peripheral zone, as we've seen, is the DCE. The tiebreaker between a 3 and a 4 in the transition zone is diffusion. So it's useful. The diffusion is useful in both areas. So this is a PI-RADS4 lesion in the transition zone. You can see again, these are BPH nodules here, very well defined black margin. And this is a homogeneous area of decreased signal intensity, which is different to any of the other lesions. It also, it demonstrates decreased signal on ADC. It's measured at 660 with increased density on high BV diffusion imaging. So that's a PI-RADS4, less than 1.5 centimeters, confined to the transition zone. It does enhance, but I don't care. It makes no difference. Okay, so the PI-RADS5, so you should think about PI-RADS4 and 5 as being homogeneous decreased signal intensity and with a poorly defined margin. You can see they're often lenticular in shape, so they're lens shape. Here we are, here's a PI-RADS5 lesion in the transition zone. You can see a well-defined margin, lack of the well-defined margin, and homogeneous decreased intensity. You can see it here on the coronals. Here it is here again. Decreased signal in ADC, increase in high BV diffusion imaging, PI-RADS5 greater than 1.5 centimeters.
Just going to grab your cursor for a minute, Richard, because I'll just check. It looks like we may have a question coming in here. We've just got a question coming in here saying, did Richard say the PI-RADS3 lesions should be biopsied as 50% of them will be 3+4?
Yes, what do the urologists think about that?
Does he mean 50% of the cancer diagnoses? I understood the risk of cancer in PI-RADS3 was much less than 50% overall.
I think we had this experience with the Wesley. I think when we first started, our diagnostic rate for cancer in PI-RADS3 was about 50%. But then as the team gains knowledge year on year, that dropped to about 20% or even slightly less. So I think it's whittling away the guesses really. And as you gain experience and get feedback on the histology, you gain more confidence in what you call 2s and 4s and you have less 3s. But I think in the literature, the rate of cancer in PI-RADS3 is between 20 and 50%. That's true. I think a lot of it depends on the quality of imaging and the quality of your reporting and even your biopsy qualities. So I think if you're early on in your MRI program, you need to biopsy virtually all the PI-RADS3s. Obviously not patients that, are not going to be high risk, but use your other parameters like PSA density, PSA velocity, etc., family history. But we certainly saw a drop as the Wesley MRI program got more mature after 5 years. It dropped to about 20%. Would that be fair, Richard?
Yeah, I think that's fair. But I think the bottom line is if it is a PI-RADS3 and the patient should be biopsied, then you should target those. That would be my feeling.
Yep. Okay. Thanks for that.
But I agree, and it's a marker, as you say, it's a marker of quality. Really, if every report comes back as PI-RADS3, then you probably should be using a different provider.
Having said that, I mean, PI-RADS3, this is a bit of a conundrum because on the other hand, PI-RADS3 is a genuine report. I mean, as you've just explained before, you know, if you see a lesion but the ADC number is not low enough, in other words, it's not dark enough, then you're kind of obliged to report it as a PI-RADS 3. Having said that, what you're saying is that those lesions are really much more rare. The more experience, or it seems to be that they become more rare the more experienced a radiologist becomes.
Yeah, I'm sure that's true.
Yeah. Okay, well, we better keep going in the interest of time.
Let's talk briefly about seminal vesical invasion then. So these are the actual, this is normal here, abnormal here. Axial T2 image with these multi-locked fluid intensity components in the coronal image here. When we've got focal decreased density within them on the T2 image, you can see here on the axial, here on the coronal, with focal restricted diffusion, decreased density on ADC, and focal contrast enhanced, we can be confident of seminal vesical invasion. This is quite obvious and quite marked and unusual.
Yeah.
Okay, so this is what I think we should be using MR for the patients who have got on active surveillance to rule out a high-grade PI-RADS 4 or 5, where the ADC is the most useful sequence. For a patient with a rising PSA with a negative biopsy, particularly patients who had a truss, to look for anterior transition zone lesions. The most important thing, I think, is for us to give the surgeon a target for biopsy. And we're not a perfect test by any means. We don't pick every cancer, but when I think that's our biggest single role, is to provide a target.
It's interesting, Richard. I reckon that slide that you show there is almost a bit of a history lesson, because it's kind of how MRI has introduced itself into our practices over the years. And number 3 really is the big one now, where it's basically before any biopsy that we do. And that's what's, you know, entered the guidelines. So, but obviously, you know, it's got a role in those other aspects as well.
Yeah, this would be 80% of our work, maybe more.
Yep. We might skip through these next couple, Richard, perhaps, just in the interest of time. I'm just mindful of ticking, and we've got a fair bit to get through. But perhaps those last couple are worth it in terms of 2.1, just to get people, if you go back a slide, perhaps.
So the changes to 2.1 are minor. As I said earlier, the image acquisition now demands that we have a B value of 1400 as a minimum. There is no decision on whether 2000 is better, worse, or the same. We do assess the central zone, which I haven't really addressed in this situation, but you probably should think of the central zone as a mixture of the transition zone and the peripheral zone at the base. It's bilateral and symmetrical and can be quite tricky. If the lesion involves the anterior fibrous stroma, we should use the transition zone criteria rather than the peripheral zone criteria. And as Jeremy said before, some of the transition zone BPH nodules, if they're very well defined, they can be PI-RADS 1 or PI-RADS 2. But if they do, even if they can be very well defined and they do demonstrate focal restricted diffusion, which is markedly decreased density on ADC and increase on high B value, we should regard that as a PI-RADS 3. So that's a tiebreaker. And there was no recommendations regarding biparametric MRI, that is using MRI without contrast.
Yeah.
So we've talked a bit about this, about what to biopsy and when to biopsy. This is the most important part of this slide. We want to do the MRI before the biopsy, not after the biopsy.
Yep. That's
probably all I need to say, I think.
Terrific. Richard, thank you. Let me just check if there's any other questions come through before we go to Andrew's presentation. Let's just have a look. No, it looks like, oh, hang on, here we go. Okay, one of the attendees has just questioned, the slide mentioned assessing cancer found on TERP. Is there an optimal time to get an MRI post-TERP? So that's in case, Richard, we get a bit of cancer coming back perhaps unexpectedly on a TERP resection as opposed to a biopsy. You got any thoughts about that?
I don't know the answer to that, but I would say at least weeks, not straight away. It's not usually an issue for us because it's an uncommon situation. And so by the time we get to those, there often are weeks to maybe a month. Well, the other more important one is I did flash over is granulomatous prostatitis. Mm-hmm. If the patient has currently got prostatitis, I would say we shouldn't scan that patient for 3 months. until the patient's been treated, because we will get a granulosing prostatitis can look exactly the same as a PI-RADS 5 lesion.
Yep.
Yeah, that's an important point. Richard, do you want to say a couple of words just about, for the attendees, about windowing your DWI and ADC windows when you're looking at reports, looking at scans, and also the importance of having the T2 up in symmetry with the ADC and using your cursor like you mentioned?
Oh yeah, well, everybody has a different way of reporting, unfortunately. Windowing is very normal for me. So you've got to get it flattened out so you can see, if you look at the ADC, for example, so you can see each of the nodules separately. If the window's too narrow, it's all sort of bleached out and too bright. If it's too flat, then you lose all contrast. I spend most of my time looking at the high B value diffusion imaging, I've got to say. That's where all the money is. And I usually start there and work backwards.
Yeah, I agree.
Got another question come in, Richard. Do you have any tips for pitfalls of the central zone? Saying that they can...
That's a different talk in its own right. The trick about the central zone is it demonstrates restricted diffusions. That is to say, it looks like a tumour. But and it can be asymmetric. I think of it as like I haven't got a slide of this, but I think of it like an upside down old telephone, like you used to answer with your hand before mobile phones came around. It looks like an inverted one of those. And you can see it on the coronal, it looks the other way around. So I'd look in both the axial and the coronals up near the base for something that's bilateral and near symmetric with restricted diffusion.
Terrific. All right.
And not enhancing with contrast.
Richard, thank you for that presentation. Andrew, are you ready to...
Yeah, so if you want to stop sharing your screen, then I'll pick it up.
Done that.
Okay, so we should be able to do that. Fantastic. Yep. So thanks, Jeremy, and thanks for the invitation to be involved. As a pathologist, I realise there's a talk on radiology, so I'm going to keep mine relatively quick and just kind of probably point out a few of the things that we do as pathologists and what we've gleaned so far from the correlation of our pathology and the MRI and intraoperative findings. So I won't spend too much time, but probably, most people kind of know their pathologists, never see inside the lab to see what's going on. So I've got a few slides where we might actually see where we've got some of that information that's been so useful in learning and correlating findings. So our main role is the presentation of histological findings. That's both biopsy and radical prostatectomy. But as I've said, also this involvement in the multidisciplinary MRI correlation sessions that we've had with Jeremy and Richard have been really, really beneficial to all three parties. So our biopsy reports are presented very simply. Obviously, all the components that are required and separation of the template biopsies and the target biopsies, and we report them as labelled. Sometimes we get these target biopsies that just say target, but I would encourage all of you to actually let us know where the targets are so that then there's a permanent record of where that actual lesion or where those target biopsies have come from. Historically, sometimes we come and it says target and we don't actually know where those biopsies have been acquired. Also, sometimes we get this kind of presentation of core biopsies, which isn't as sorry, do you recognise that, Jeremy?
Having a dig at you, by the way. Yep, carry on.
So I guess I use this example because some places use pictorial diagrams for their biopsies, and as a group we've discussed using them, and they look really nice, but they can be ambiguous to the actual PRO's report. And also what they do, or our feeling is what they do, is that they then place on a picture and make a definitive statement of where a particular, amount of tumour or Gleason grade is. But we can't, as pathologists, guarantee on our little diagram that that's exactly where the biopsies have come from. So we've always steered it clear of that and just presented objective, whatever's been labelled, we present it that way. I think it probably needs to be, the report needs to be taken into consideration by the urologist of how they've acquired those, because there will be confidence at times and a lack of confidence at times in where you've actually acquired those. And also these unusual templates can be difficult to present. So the other component, and this is the more important one, when we're using, like learning from MRI or learning from the MRIs, is these volumetric reports. So we present our radical prostatectomy reports as both prose reports or structured reports according to the data sets that we're required. But we also present our radical prostatectomies as a pictorial representation. I thought I'd just go quickly through that just to show you how we produce that. So a radical prostatectomy is acquired and fixed, inked accordingly, and then on this right-hand side, you can see the standard way of cutting a radical prostate is to cut serial transverse sections and then sequential parasagittal sections of the apex and the base. And we get something relatively similar to this in most cases. It's somewhere between 3 and maybe 6, up to 6 transverse sections, depending on the size of the prostate. But usually the apex and the base are relatively standardized size. From there, these are processed, and then if I go back one, you can see that there's marked here. These some people do whole mount sections of a whole transverse section, but they tend to take a little bit longer. So we cut our sections into quadrants, and you can see those developed on a slide here. So this is what we see on a slide, and when we're looking at it histologically, we mark the tumour. And it is really relatively rough. You can see probably there might not be tumour in this area here, but it's been marked. So it's not an exact outline of the tumour, but it's really quite close. It's done microscopically. From there, our scientists then reconstruct those the pictures or the slides by scanning them all. And you see this again, a relatively rough outline of what the scan slide would have looked like, and then we colour in the area that's got tumour. We also represent areas of seminal vesicle invasion. Extraprostatic extension is yellow, and positive margins are in red here. So I've got these orange tumours here. Standard is to represent an index tumour as the highest grade tumour. These other black ones here are the lower grade tumour foci.
Andrew, I've got to say, I find those representations extremely helpful, not only because you can obviously refer them back to the imaging that you've had prior to, and sort of get a sense of, how well the imaging correlates or not. Usually it's very good, but not always. But also just to, potentially for future planning as well, knowing exactly where the cancer actually was, not just a verbal report, which only gives you a sense rather than actual knowledge of where the tumour is. I think I find it extremely helpful, particularly if there's a positive margin. It might help you in terms of where you focus your radiotherapy and all sorts of things. So yeah, I think it's really very helpful, and a hugely helpful component though if you're going to do multidisciplinary meetings where you're really focusing on the prostate MRI so that you can get that visual feedback.
Yeah, well, as I said, this has been extremely helpful in our meetings, correlating what Richard's saying and you guys are saying.
Yeah.
So from that, I just thought I'd flick through quickly about what we know from these kind of meetings and the correlation, and also from literature. We can expect, and this relates somewhat to what Richard's just been talking about. So detecting 80 to 90% of significant cancer. So we don't see a lot on MRI of these 3+3. So invariably what we'll see when we go back and have a look, a lot of these other smaller low-grade foci won't actually be evident, but a tumour this large will obviously be evident on MRI, especially if it's higher grade. So we can miss small foci, anterior foci, low-density foci, and I'll show you a couple of examples of that. And some of the heterogeneous morphology, we've got to be a little bit careful about. Obviously, this is the kind of the upside of it. It has the advantage of missing some of those insignificant cancers.
Yeah.
So this relates a little bit to what Richard has just been talking about. Visibility tends to increase as grade increases. This is to do with the water content within epithelial cell cytoplasm. So with that in mind, obviously gland to stroma ratio becomes really important, and with gland to stroma ratio increasing as most tumours, increase in size. So we see these all would be lined by epithelium, but there's intervening stroma. When we come down here, there's a lot of cells in here, very little stroma, and I think that's why we're seeing, how it correlates on MRI. This is also relevant though when we talk about tumour cell cytoplasm volume. So some of the cells that we'll see in, say, things like ductal carcinoma, where there's a lot more abundant cytoplasm, may also influence what we're seeing on MRI. So this is just a pictorial representation of what I've just been saying. The epithelial nuclei here are much sparser than something like here with Gleason pattern 4. There's a lot more cells in this within that high power view than in here. They're both equivalent, but a lot more cells in this one here, a lot less stroma. When I've said visibility tends to increase, but see, this is pattern 5 tumour and there's a lot of stroma around there. So these little areas that I've got circled here, I think they're the parts that we've got to be careful of. These are some of the potentially invisible tumours, because you can see here that this really wouldn't show up as a highly cellular tumour. What we do know that it's actually really good at detecting some of the important prognostic subtypes of carcinoma of prostate. This is intraductal carcinoma, this is large cribriform, intraductal type carcinoma, and ductal carcinoma. All of them very cellular. We can't sub-classify, but we certainly know they're visible. We've learned this, and certainly in the literature as well, that MRI, I wouldn't say grossly or significantly, but it certainly underestimates the size. Whether that's because some of at the periphery, prostate cancers tend not to be sharply circumscribed. They tend to trickle into the surrounding stroma. So probably the cellularity of the stroma at the periphery, cellularity of the tumour at the periphery is less than centrally. So maybe it's that we're just not picking up very well the outside of the tumour. It also may well be that there's some of those, more better differentiated areas of tumours are sometimes seen peripherally as well, some of those Gleason 6 areas. So the extent of invasion, I've always kind of been a little bit critical in our meetings about how PI-RADS deals with extraprostatic extension, and it really is just a surrogate marker. What we see microscopically is we can see sub-millimetre extension of tumour, whereas really the resolution is not going to be like that on MRI. So what we really, my impression of what Richard tells us is that the assessment of potential EPE is really based on extent of involvement of the tumour at the capsular margin. So if there's obvious extension beyond here, then that would be probably visible. Again, I'm not the expert in this area, but what I will say is this may be visible, but these tiny little glands trickling into extraprostatic fat will not be visible on MRI. So I think it underestimates. We end up seeing a lot more EPE than probably is initially assessed or initially suspected on MRI alone.
We'll have a look at that as we get onto the cases in a sec. Yeah, that's a good point.
The other thing that's obviously we're starting to look at is whether or not MRI features look at, or MRIs are any good at actually kind of picking up. We know that they can pick up higher grade tumours and they pick up those better, but whether or not there's any phenotypic or molecular hallmarks that can be correlated for MRI appearance. And again, there's literature suggesting that might be the case, but it's certainly not in regular practice at the moment. Morgan spoke about this earlier, or Richard and Morgan both kind of raised it, and I guess that's the one thing that we do see, these false positives. That was the only other thing that I wanted to talk about from a histological perspective with an MRI correlate. And that's really, this is a prostatic gland here, and you can see why that may well show up as an MRI lesion. These are all inflammatory cells, eosinophils, lymphocytes, plasma cells. So it's a really very cellular milieu within the stroma, and that's probably why it appears like that on MRI. So just in summary, when compared to the histopathology, We know that it's good at detecting most significant cancers, including those subtypes, but watch out for those high-grade ones and the potentially false positives. We know that it probably underestimates tumour size. We know that it probably underestimates or potentially is just a surrogate marker for extra, so it's not a real marker of extraprostatic extension, but we know that the broader the extension to the capsule, the more likely there is to be extraprostatic extension. And it's not currently useful for grading phenotyping or other known prognostic factors, but maybe in the future.
Terrific. Andrew, thank you very much for that. That's great. If you wouldn't mind stopping sharing your screen, and I'll share mine again, and we'll have a look at these cases. Should be able to get that up now for you. So hopefully everyone can see this now. This is, as I mentioned at the start of this webinar, we wanted to actually go through some real cases using the MRI Pro program that we developed as it's ideal given that we're doing this webinar format to actually do that. So you can obviously just watch this on your webinar screen, but if you want to actually do the program, as in these 5 example cases, then you can potentially flip back and forth between the 2 screens and actually have a go yourself while we're sort of talking you through it. But just to give you a bit of background, if you're not familiar with this screen and you want to have a go yourself, I'll just quickly run through the functions on this so that you can do it pretty easily yourself. So you'll see here that there's a blue button with either a number 1 or 2, and that just basically divides it into either a single screen or double screen. As you probably know, most radiologists will use at least a couple, sometimes 4 or more, in fact, screens as they're actually running through it. Probably for most of us urologists, 1 or 2 at the same time is probably all we need. We've got these thumbnails down the side here, so it'll automatically come up with the T2 axials, but we've deliberately put the sort of the top 3 series where the money is for prostate MRI. So T2s, high B value, diffusion weighted, and the ADC maps. We do have other series further down, but in the vast majority of cases, you're going to find most of the information, at least for the primary, and I do want to focus on really the prostate in this particular webinar. There may be other occasions where we can look in more depth at looking at lymph nodes and bony mets and things like that, but really just focusing on the prostate itself for tonight. But if you did want to scroll down, you can just use the little white arrows to go up and down. And then in terms of choosing the actual thumbnail that you want to use, you just click in the center of it and it'll come up over there. Now, you can then just use your mouse or your trackpad to just gently scroll through, and you'll see that the scrolling has been linked. So what you see in the T2 is also going to show up on the other series that you've got on display here. There's magnifying. This is just the scrolling button. There's a measuring tool here, which you'll be able to use, and you just click on 2 ends of what you want to measure to do that. Then we've got brightness and contrast, and that's just to return to where you were previously. So it's really very quick rundown on how to use this particular program. We've tried to make it as simple and intuitive as possible. So I might hand over to Richard. Now you should be able to, let's...
Can you share that screen?
Yeah, so I'm sharing it, but I'm also hopefully giving you permission to now use the mouse.
Okay, so... Is
that working for you? There you go.
Yep, okay, so why don't we go...
So I think given that we're short on time, Richard, I think if we focus on those series in particular, because we may not have time to worry about any metastatic disease. So
okay, so let's just have a look at this first one. This is a relatively small volume prostate, transition zone centrally, peripheral zone peripherally, and you can see there's a focal area of decreased density here. There is actually if you look at the capsule should look like that black line. You can see there's some irregularity in the capsule here. If I put that up, if we look at that, and then we look at the ADC and the high B value. So most people would put these 2 together, and as we scroll through those, let's look at this lesion. So here we start to get there. It's about the mid prostate, and it keeps on going down to the apex. If you get a ruler out, you'll find that's greater than 1.5 centimeters. The pictures on your right are the high B value. It's very bright on high B value diffusion imaging, and it's very dark on ADC. So that's black and white. That's a PI-RADS 5 lesion because it measures over 1.5 centimetres. There probably is some extracapsular extension that's subtle here. If we keep on scanning through, you'll see on this picture, there's two further areas of decreased sensing on ADC and high increased sensing on high B value diffusion imaging. That ADC will not be as low as the other one, so these will be probably lower grade tumour, but there is two other foci in two other different areas.
Scroll up slightly on the ADC map on the left there, Richard. I think you'll be able to see them a bit better, just ever so slightly. Obviously, slightly just out of sync a little bit. Keep going. There you go.
There we go. Yeah. Okay. So they're not quite. So that's much more obvious here. They're quite markedly decreasing intensity. So there's a total of 3 lesions, 2 PI-RADS 4s and 1 PI-RADS 5.
That lesion on the left of the prostate, Richard, if you go back to so that you can see that, when you measure, and this is a little bit academic, but when you measure to determine whether it's PI-RADS 4 or 5, what series do you typically do that on?
That's a little bit controversial. PI-RADS would say usually on the axials because they only really look at the axial diffusion imaging. We do it on an axial and a sagittal. And in the peripheral zone, you should use the diffusion. In the transition zone, you should use the T2. I actually look whichever one is biggest in. And whichever one is biggest in, that's what I measure. Because we do know that we underestimate the extent of tumour on MR. At least 10%, maybe more. And so what we're really looking at on MR is the core of the tumour. So I look at it, whichever is the bigged one, on whichever is the most obvious sequence, and I measure that.
Yep. Okay.
Which is not quite strictly PI-RADS.
And what about, I'm presuming that when you measure or when you report for extracapsular extension or extraprostatic extension, you do that on the T2s?
Yeah, usually, yes. Yes. So what I look for is, as Andrew suggested, the longer it impacts, it touches the capsule, then the more likely it is to be a higher grade. It's obviously important for you to know whether it's contiguous to the capsule or separate to the capsule, because it may determine which way you'll approach that patient surgically. But if you look here, you can see the capsule is clearly different to the other side. So I'll look for how long it touches the capsule for. I'll look at so-called capsular regularity, like I would call that capsular regularity. And sometimes, but uncommonly, you'll see a clear extracapsular mass. Yep. So the rectoprostate angle is really in here, which is really a leftover from the endorectal coil literature. It's not as useful for us, I think.
Okay. All right. So what we might do is go through just to show everyone how this answering system works. So Richard, you're saying this is a PI-RADS 5 because we know it's more than 15 millimetres. So that's, we'll click that button. There are 3 lesions, so greater than 2. As I've mentioned, for the interest of time, we're going to skip through any sort of metastatic disease, but you'd say that there was extracapsular extension, and I'm just going to click through these in the interest of time. Now, when I read this MRI, I read that lesion as being about mid-prostate in the
biggest area of it,
peripheral zone. So this last question is really very clinically oriented. In other words, the whole point of doing these MRIs is to work out if we're going to do a biopsy, where are we going to aim our targeted cause? And we can come back to how we actually do biopsies in a minute, but I would click that one, and then we can have a look at the answers. And Andrew might be able to take us through the answer here. So we got it right. Andrew, you can see that?
Yep, I can. So that's our index lesion. It's as described by Richard in the report, and the 2 smaller lesions that were visible, but not the index tumour. So that really is extending from the base all the way down to the bottom of the apex. We're representing here extraprostatic extension. Yep. And seminal vesicle involvement.
Yeah, so that's interesting. There is a bit of SVI in this particular case, but you can see how tiny it is. So it's no wonder we couldn't pick it up on the MRI in that particular case. And then in terms of the verbal report, this case did actually have some lymph nodes, but as you can see, very much a significant cancer, 4+3. and including extension into that left seminal vesicle. Okay. Let's go to the next case. Just let it load. And I think because we're getting short of time, again, if you've got MRIPro.io up on your own computers, then please feel free to have a play with it as we're talking about these. But what we'll do is, I think we'll just let Richard sort of take us through them so that he can basically tell us, what he goes through as he's reporting these. Now, in a very truncated fashion, obviously, because we don't have all the series on this particular program, but we've got the most important ones.
There is a question as well, Jeremy.
Oh, okay. Thank you. Let's have a look and see if I can see that.
I'll just type a brief answer to it.
Oh, okay.
Oh, okay.
It's in the answer column.
Oh, yeah. So just I guess for the benefit of all, just in case you can't see all the questions and answers. So the question was, in assessing seminal vesicle invasion, do you look at T2 phase imaging, Andrew? Richard?
I'm a radiologist, we look at every sequence, but if you had to pick a single sequence, I'd probably look at the coronal T2A images. That's where you see it the best. But I would also say that almost all seminal vesicle invasion, you'll see an abnormality on the T2. They almost all demonstrate restricted diffusion, and they almost all demonstrate contrast enhancement. So you do need to look at all of them. I find the sagittal diffusion is quite useful for that, because if we just go back, we go to the next case for a moment, Jeremy.
Yes. Yep. Hang on. Let me just go back to that.
Okay, if you look here, so this is the next case, but you can see there's a TURP cavity here, but this is the seminal vesicles here. And the tumours that involve the seminal vesicles are at the base. And so you see that extension there very clearly on the sagittal diffusion. So if there's focal diffusion restriction, focal contrast enhancement, and focal signal abnormality within the seminal vesicles, then I'm happy to call that. Okay, so this is a small volume prostate, previous TURP cavity, and we then look at the axial T2s. Okay, so we're just scrolling down there. So there's the seminal vesicles there, no black markers that I can see. And as we continue to go down, we can see the transition zone is bubbly, if you like. No focal abnormality, and there's no focal abnormality in the peripheral zone either. There's linear signal abnormality. Maybe I'll be a little bit concerned about that, and I'll interrogate that area more closely on the ADC, on the diffusion rate.
Richard, do you mind just zooming in so the attendees can see a bigger image, please?
So,
hang on, let me see if I can do it. There you go.
Yeah, that's much better. Thanks.
Whoop. Sorry. Are you doing that, Richard? Or
no, not at the moment. I'm blaming you.
All right, blame me, because it just seems to be. There we go. That's a bit better.
Okay, so I would look at these areas that look focally of decreased intensity on the T2s. I'd interrogate those on the ADC and diffusion. So if I put those two up,
just click again. Yep.
Okay, so again, these two are linked. We're going from, you can see on the left-hand picture, you can see the seminal vesicles here, nothing with restricted diffusion within the seminal vesicles, nothing going bright. And as we go down, there's a little bit of a lag. We're getting to the prostate itself now. You can see the TURP cavity here, but I can't see any focal area of restricted diffusion. There's nothing going white on the right-hand picture and nothing going black on the left-hand picture. So no focal area of restricted diffusion in the transition zone or peripheral zone. I would call that a PI-RADS 2.
So Richard, if you've got all that information on T2 DWIs, do you? I know you certainly see some value definitely in DCE, but if you've done all this first, do you actually still look at the DCE just as a backup?
Always, and one of the lessons I've learned from PSMA PET is sometimes you'll see a focal lesion on PET that you don't see on MR. If you go back to the MR, you often see it on the DCE. So that's so I would recommend you. So sometimes they can be extremely subtle, and even I report outside of PI-RADS a little bit, And if I see a focal round enhancing lesion in the peripheral zone, and it's normal on the ADC and T2, I'll still call that a PI-RADS 3 because I think you should biopsy it, because I've seen that on multiple occasions where you'll see an abnormal PET, and the only thing that's abnormal in the MR is the DCE.
Okay.
Have you had that, Morgan?
Yeah, I agree fully. I mean, I vividly remember a case from late last year that was exactly the same. High-grade tumor showed up like a light bulb on the DCE and nothing on the other two. So even though we use it less and less, and it's only helpful in 5 or 10% of cases, it's sometimes it gets you out of jail.
Yep.
So it's a difficult one because obviously it adds time and cost and a small risk to doing the scan for the patient.
Yes. Yeah. Okay, let's get through these cases. So, Richard, you've reported this as a PI-RADS 2. Which none of the other questions matter in this case. So I'll just submit that answer and see what we've got. So all of these cases, by the way, have had a thorough transperineal biopsy. So one of the questions that's come up is actually, can MRI tell us which patients not to biopsy? Well, these cases were all recorded in the period when we were still routinely doing biopsies transperineally on even on negative MRIs, and I think that's an important point as well. I think probably by now the vast majority of us are at a stage where we have become familiar and confident with whoever we are using as our radiologists, and then comparing those results to their biopsies. We know how accurate the MRI reporting is in our own practice, and therefore, in the vast majority of the time, we can avoid doing any biopsy if the MRI is negative. Now, the really important caveats to that, and Morgan's already alluded to this in his text reply, and Morgan, one of the things that I certainly use in addition to a negative MRI to avoid a biopsy is looking at that PSA density. It's such an easy parameter to measure, and if the PSA density is less than 10%, and you've got a negative MRI in an experienced radiologist's reporting hands, then your chance of missing something is less than 10%. And when I say something, I mean significant cancer. What about you, Morgan? Are you still biopsying negative MRIs?
Oh, look, almost never. I mean, I do when the PSA is high, when it's getting into 12, 15, 20 range. I replied in my reply there about the dirty peripheral zone, so Richard might want to comment on that. You often get more than just geographic T2 changes on the peripheral zone in the T2, and if you get patchy changes on one side, you get a bit nervous. Is it just unilateral prostatitis or is it a tumor? So I would biopsy the occasional one of those. But I, like you, I've been lucky to work in centres where the radiology is very high level, the scan quality is high level.
Yep.
And a key thing with Richard, this is sort of unsaid but obvious, I think it's vital that we send the biopsy results, copy them to your radiologist so that they can do quality control in-house. And I don't think most people do that, but that's really how your whole service gets better.
It's a truism of radiology, I think, is that you learn more by your mistakes than what you get correct. And getting feedback is incredibly important.
Yep. Right, well, why don't we just plough through the cases. I'm mindful that it's 8:30 and people's attention spans are probably starting to get pretty short, but we've only got a couple of cases to go. So perhaps, Richard, if you could...
Do you want to skip case 3 and we'll go on to 4 and 5?
Yep, we'll have to just answer it. That's not a bad idea. Let's do that, even if we get it wrong. Okay.
Yeah,
so
okay.
It's a good idea. Okay.
Okay, so we'll go back to here. Okay, so again, this is axial. We'll start on the axial T2s. Seminal vesicles coming to vision now, which look normal. So we get these sort of fine lines are really a PI-RADS 1 or maybe a PI-RADS 2. I'll just draw your attention on the axial T2 image to this area here. So a normal BPH nodule should have a well-defined black margin it can be a bit bright or a bit dark centrally, but the margin is the most important part. This area here is different to the other two areas. It's homogeneous decreased sensitivity. They're often anterior. So I would go back to the ADC and the high B value to interrogate that area more closely. So let's pull those two up. And I'll just take a sec to load. And as we go to, so the high B value, the one with the black urine, is on the right. And as we scroll through, nothing to be concerned about so far. But we see here, there's an area here which is of decreased intensity, increased intensity on the high B value diffusion imaging. And we can see this is probably more convincing here and here. So it's, now we're talking about windowing. So that's the window, this one, isn't it?
For contrast and brightness, yeah.
Yep. So that's too contrasty, that one. So we'll just have to flatten that out. We'll be able to see it a bit better. It's going a bit slow because I'm going through Jeremy's laptop, so it's a bit of a slow response. But that does. Oh, there, that's better now. So you can see that it's more black and white with what's less black and white. So you can see it's focally decreased density on ADC, increased density on high B value diffusion imaging. It's less than a centimetre, so it's likely to have no extracapsular extension. I think this is a PI-RADS 4 lesion, and so let's keep on going. We'll go to the.
Yeah, we'll keep on going. But can I just ask, how do you, I mean, you can see that now, it's a pretty small lesion, but how do you, sometimes it's nowhere near as distinct as that in that anterior,
yes,
close to the anterior fibromuscular zone. So how do you distinguish, when so often you get in that AFMS area, a similar sort of appearance? It's not as clear cut as this case, but what do you?
Well, I think it's the shape that helps you. It's oval or it's lentiform, and it's very different to everything else around it. So all these other ones are variations on the same theme. They're a little bit dark, a little bit bright, but nothing at one end or other of the spectrum. So I do rely heavily on the T2s to look at those margins, and this is clearly different on all the sequences.
Yeah. What about sagittal views? Does that help you in this anterior area?
Well, you've got to remember with MR, we take a slice and then there's a gap, and then there's a slice and there's a gap.
Yep.
And so anything that increases the coverage will be better at. So that's why we do as a sagittal one, particularly when you're looking at a curved surface at the base or the apex. If you look on the sagittals, you don't get the lesion cut off like you would on the axial. So that's why we do it in two different planes. The diffusion is so important. I do it in two different planes.
Yeah. And for this particular case, just looking at these images here, would you say there's extracapsular extension or not? Yeah.
Too hard for me to tell. But it's small. I've got to put a ruler on it, but that's probably about a 0.6 centimetre lesion on MR. And with this, we'd have to go back to the T2s. We can go back. Sorry, it'll be up here.
Yep.
So. We're almost got to, there it is there. So there, and oops, sorry. Oh, they're not in sync. That's why I'm getting confused. But you can see this, it is contiguous with the capsule. Sorry, the lag is a bit of an issue, but it's contiguous with the capsule, but there's no irregularity of the anterior capsule. Yep. So I would say there's unlikely to be a significant extracapsular extension. Okay.
So now in terms of location, I would have said there.
Yes.
That mid-prostate, left anterior. Have a look. Oh, there we go. So we can see here, I don't know if you can read that, I'll just enlarge it. 3+. Now this is interesting, I reckon, because this was a very dark, albeit small, but it was a very dark lesion on the ADC map, and yet there's only a very small percentage of pattern 4 on the radical here. So if we go back to the actual thing, it lines up beautifully compared to what the MRI actually showed, but only a small percentage of pattern 4, which is, I think, Andrew, that's pretty, I find that interesting in that, what you were saying before about, generally speaking, the grade matches how visible it is?
Look, I think it's kind of, to an extent, it's a little bit like the extraprostatic extension. We get that right a lot because the really broad extraprostatic extension is more likely to have microscopic or histological extraprostatic extension. I think similarly, with the grade, there's a tendency that these, the high grade tumours will be more visible based on their morphology, but some of these 3+4 tumours will have a morphology that will give you an MRI appearance. And similarly, I showed you that pattern 5 before that won't have an MRI appearance. I think it's just fortuitous that we have got a relative correlation, but I don't think MRI is seeing what we see histologically. I think they just correlate most of the time.
Yep. Okay.
I think also, so there's things in the literature about the lower the ADC, the higher the grade. I think that's only relevant in the peripheral zone. Andrew, I think it's fair that there's more cells in the transition zone. Is that correct? It's a more cellular area.
It can be. It depends. It can be either. If you've got BPH, then you'll have a lot of, or you can have quite a lot of hyperplasia within the glandular component. But similarly, you may have big stromal nodules as well. So that's not a general rule.
So what I'm trying to say is that the lower the ADC in the peripheral zone is more likely to imply a higher grade cancer, but that rule does not apply in the transition zone.
Well, I think there's more heterogeneity within the transition zone. Most peripheral zones will look similar histologically, but the transition zone will vary considerably amongst, between patients.
All right, let's do one more case and then we'll wind up. So this is the last one, Richard, if you're happy to go.
Sure.
And hopefully everyone who's at home going through this has had a chance to just have a bit of a play already. But given that we're past 8:30, I think we'll just run through. Go for it, Rich.
Okay, so let's have a look at the ADC, the T2 image on your left. You see there's a lot of rectal gas here. So we actually bowel prep every patient now because gas is our enemy. So we don't like, we give a bowel prep to everybody.
When you say bowel prep, Richard, what do you actually give them?
They have what's it called, the little tube. This place, they give it to them rectally, so they go to the toilet. They have to come an hour, 45 minutes early, and it just gets rid of the gas. And the gas is a major enemy, particularly in the diffusion, which is the most important sequence. Yep. So, do you do that, Morgan?
Yeah, absolutely. So, microlax or fleet or just a rectal flow tube, it gets rid of that susceptibility artifact. So, if you see a bright arc at the back of the prostate, you probably haven't registered that there's gas in the rectum, but just drop your eyes a centimetre and you'll see it's full of gas, so it's not a good quality scan.
Yeah, it's a real problem. We used to have to call back a significant number of patients now, and now we hardly ever call anybody back. Okay, so let's...
Yeah, there you go.
Am I still going here?
Yep.
Okay, so here's the actual T2A image here. You can see there's a focal area of decreasing intensity here, measures about 1.4 centimetres in size. Now, this is at the apex, and the capsule is deficient at the apex, but even allowing for that, there is a bit of cortical capsular irregularity here. And you'll see on the high B, it's actually quite subtle on the high B value here. If we look at the same lesion on the ADC, they may not, they're going to coincide, that's good. It's obviously dark on the, there it is there, on the ADC. So black and white together, this is a bad lesion. Let's just see if the contrast is there, just to see what they look like. So this is one of the older contrast ones we do. So let's just see if that enhances with contrast.
Yeah, you should be able to scroll through that now. This K-trans, can you take us through what this actually means?
I'll get to the, so it does focally enhance, but this is an older study. We used to use K-trans. There's lots of different ways of, it's a mathematical formulation about how mathematicians analyze a contrast curve. And we used to use K-trans and now we don't. We use we use what's called the in phase. So when I showed you that diagram earlier, now we just look at the peak, and we take about 3 or 4 slices from that peak enhancement, rather than calculate it via K-trans. K-trans is just a mathematical thing, so we don't use K-trans anymore. But this does focally enhance.
Yep.
So what I would call this, we could probably argue about whether it's a 4 or 5. Let's call it a 4, but I wouldn't. It could be a 5. I think there's only 1 lesion there.
Yep.
I think there probably is extracapsular extension, but most lesions of the apex, as Andrew will tell us, will have extracapsular extension, and it's probably going to be there.
Yep.
So let's just say these ones are negative.
Yep.
And we'll submit.
Yep. There you go.
So again, we've underestimated the lesion.
Yep. Yep. Good example of that, isn't it? It's a decent lesion though, and well, yeah, you can see, Andrew, that there's that extra prostatic extension which you'd expected, and yeah, 4 + 3, or grade group 3. So
yeah, and as Richard said, this is really extending right from the apex all the way up to the base, so probably considerably bigger than what we initially thought. That's not the right one, I don't think.
Sorry, hang on. Let me just get out of that. Sorry, I've got something else coming up on my screen. That.
Yeah.
Yep. All right. Well, time to wrap up. So once again, I'd really like to thank my fellow panelists, Morgan, Richard, and Andrew, for helping put all this together and for their time tonight. I do hope that everyone out there has found it of some use and might maybe has answered a few questions you might have had about prostate MRI and how to use it, how to read it. So it's really important that, if we're going to take time to do these things, that it's actually of value to all of you out there. So please give us your feedback. In fact, we'll send you out a really brief survey in the near future just to get your ideas about whether you found that worthwhile or whether you've got any suggestions of how we could make it better if we do any of these at some stage down the track. But thanks again, everybody, for joining in. Thanks for your questions as well, for those who contributed those. And we will see you soon, even if it's not in person. So I hope you all stay well and take care. All right.
Thanks, Jeremy.
Thanks a lot, everybody.